So Dr. Monica Peak is Associate Director of the Chicago Center for Diabetes Translation Research. She's also Executive Medical Director of Community Health Innovation and the Director of Research at the McLean Center for Clinical Medical Ethics at the University of Chicago. She is also the Ellen Block Professor of Health Justice there. She provides clinical care, teaches, and does health services research with a focus on health disparities. So, but I know Dr. Peak before she was like all these wonderful things. But she's always been wonderful, though, I have to say. I think we met when you were a medical student here at Hopkins, right, Monica? Yeah.
Yes, indeed.
So we go a long way back, and we connected even back then. I'm sure you're going to learn more about this when she gives her talk, but this woman is a dynamo. It has a great sense of humor, and I don't know when she gets everything done in her life, but she manages to do that with grace and elegance. So that's a little bit about her. She's highly published, has been the PI of multiple grants from NIH, Robert Wood Johnson Foundation, the Greenwald Foundation, and also has been featured in several national outlets lately. But there's some things about her that you may not know. So we just want to see how well some of you may know this exciting and delightful and brilliant clinician scientist. So I think many of you already could guess some of her music preferences, but you may not know all of them. So you know, other than Al Green, who do you think might be some of her favorite musicians? Any guesses? I know she and I share one favorite. And other than Al Green, that is. Somebody's guessing Isley Brothers. Okay, we're going way back. Sam Cooke and the Temptations. All great answers. Baker. Wow. Well, these are all great answers, but not, Burna Boy from Chittima Ibe. Well, these are all great answers, but I don't see the right one yet. Well, there was a certain young lady who hailed from New Jersey, I believe in the 90s, early 90s, who really became quite famous. Well, people are getting closer. Whitney Houston. There's somebody else.
Queen Latifah.
Queen Latifah. Lauryn Hill. There we go. Bingo. That's the answer. So yeah, Lauryn Hill, of course, the Miseducation of Miss Lauryn Hill being one of her famous albums, and the song. What's your favorite song from that album? Or was it from that album? I think it was. Yeah.
Yeah, there's so many. I love the whole album.
Yeah.
Just every song on there.
Yes, I know, she's amazing. Okay, so that's one question about her. Tell us, let's see whether you all can guess. She is quite athletic. And so I want to see how many guesses we have for she's actually an instructor for a certain kind of sport. Maybe I'll give you, people are already guessing. Pilates, yoga, tennis. Any other guesses? Dance, volleyball. Okay, we got the right answer already, actually. I'm just letting you guys go on for a while. She's a yoga instructor. Is there any surprise with how zen the music was? And, so I think that was a tip off. Okay. So we got a couple more fun facts. As serene as she appears, she actually can be pretty adventurous. So I want you to guess one thing that she's done that I bet many of you haven't. I know I haven't. I wouldn't even dream of doing this. So.
Good.
Monica, have you written about this somewhere?
No, I don't think so.
So Deidre got it skydiving. Absolutely. I actually just read, well, I don't want to give away, I'm not going to tell you what book I just read where somebody was skydiving, because then I'll ruin it for you. But one day I'll share.
Mhm.
I just read a really good book where somebody that many of us know was talking about an experience with skydiving. So where did you skydive?
Skydiving, when I was a resident in Stanford, and it was a fundraiser for Ryan White. And so it was someplace, I don't know, large grassy field. And yeah, I remember the first couple of seconds thinking, I'm fairly sure this is my last few minutes on Earth. Like ground rushing up at me. Like, what have I done? Anyway, it was great. It was beautiful. Yeah.
Now, I guess the final question is, were you a mother at that time?
No, you're so right. You're so right. But I don't know. Like me and my kids have been parasailing, where you're on with the little hot air balloon way up, and it was pretty high. I took both my kids with me, so me and my son, and then me and my daughter, and they were like maybe 8 at the time or so. So, so I'm trying to get them to be adventurous and stuff.
Well, she just gave away the last clue, guys. So she's the mother of twins, a boy and a girl. So that was going to be the last question.
Yeah.
So anyway, so you know a little bit more about our speaker, and now I'm going to turn it over to the one and only Dr. Monica Peak. Please join me in welcoming her.
Thank you so much. I have never had a beginning like this with my favorite music, people talking about Al Green in his white pantsuit. I'm gonna try and share my screen, which is, let's see here. All right, play from start. So much fun. Thank you for having me. Thank you so much for having me. Lisa has been my North Star for so long. It is just a pleasure being here. I'm gonna start crying. I'm just eternally grateful for all that you've done for me and for everyone who tries to walk in your shoes. And so it's a pleasure to be here. It really is a pleasure. I am going to talk a bit about.
I paid her to say all of that.
Yeah, we're looking for the check in the mail. Lessons in racial equity from the COVID-19 pandemic. This is something that, I'm sure all of you have been thinking about. Everyone has been thinking about these things. And so none of this hopefully will be new, but just perhaps a way for us to continue engaging in the discussion about racial inequities, how much we have all been leaning into the conversation around racism in the past few years, and how the pandemic has coincided with and exacerbated racial disparities in health care and health outcomes. So I'm going to start by just giving a head nod to the places I sit on campus, including the McLean Center for Clinical Medical Ethics. I'm a bioethicist, and I do diabetes work, I practice at the University of Chicago, and I'm also a part of the Bucksbaum Institute for Clinical Ethics, which promotes patient-provider relationships. And I'm going to start by giving a shout out to Lisa's paper that she just had published in JAMA with one of our co-mentees, Shantanu Nundy, because it was a wonderful, beautiful piece, adding another aim around healthcare improvement, health equity. And so it has already made a huge impact on the national discourse around equity in healthcare. And so I just wanted to thank you again, Lisa, for all that you do. So just to make sure that I'm level setting, obviously probably no need with this audience, but I always want to start out by making sure that we're speaking with a common knowledge. So structural inequities are the policies, laws, procedures, and norms that differentially limit the access to goods, services, and/or opportunity. So things like segregation of schools, racialized residential housing, discrimination in banking and lending practices, unfair criminal justice practices, justice policies, and unequal access to just the basic human needs like food, clean water, clean air. And when those structural inequities exist, they don't just randomly occur in a population. They fall along fault lines in our population of social identities and those whose social identities are marginalized. So all of us have multiple social identities, and they're either associated with more or less power, depending on who we are and where we fall in society. Of all the possible identities, and this is only a partial listing here, in our country, race is the social identity that has the strongest signal for being one that's polarizing and one that has the most ability to marginalize a population. And so we say that structural inequities based on race is called structural racism. And there are lots of different kinds of racism, but structural racism is the one where you're talking about differential access to goods, services, and opportunities, differential access to risk, and things like that. And so there's a growing body of research looking specifically at structural inequities and how they may be associated with or impact health in the long term. So things that I was just mentioning about residential segregation, things like community violence, food insecurity, other limitations in the built environment, things that we build with our hands in the community, racial discrimination, substandard housing. All of those things have been associated with the chronic kinds of medical conditions that I, as a primary care physician, deal with on a day-to-day basis. Obesity, hypertension, diabetes, chronic lung disease like asthma, cardiovascular diseases. And this is not a complete listing. Cancer is also included. And so when we think about the impact of chronic medical conditions on the total morbidity burden and the risk for things like COVID, and the economic impact it has on our society. And then when we also think about the fact that we know that these social and structural determinants really have a much larger role to play in people's health than, medical treatment, then we have to really step back and say, what is racism costing us as a society? And what is the cost of trying to mitigate racism? What will it take for us to ultimately decide that we have had enough, even if I'm not directly, being marginalized or affected by racism, it is costing me as a member of the society. The emotional blowback affects us all, and the economics affects us all. And so we know that societies that have huge sociological gradients in race and class and those kinds of things, that as a society, everyone loses. In general, the whole society's health is worse. In general, the median income and education level is worse. And there are lots of reasons why, and those have been articulated really well in some books that have been published recently. But racism hurts us all, not just the racially marginalized. So what I'm going to talk about is some of the lessons that we all know to be true about disparities, but how they have been particularly highlighted in the COVID pandemic. So one is that we need to collect accurate race and ethnic data. That is as clear as day. But that is something that, particularly during our last presidential administration, had a lot of pushback on because just like testing for COVID, if you don't test for it, you don't know it's there. It's like it's gone away. And so we knew, particularly at the beginning, that 50% of patients who were getting tested had missing race and ethnicity data within this country. Now, it was an available slot. You could put in your race and ethnicity data, but it wasn't a requirement. And so as we were trying to track this disease sort of within areas, local areas, and across the country, our efforts were being hampered by the fact that we couldn't really identify fully and completely the populations that were most at risk, who was experiencing the most disparities, and where those were going and changing over time, because all of our information was not complete. And so there were some efforts over time to try and change those policies, make them more likely that people would fill in those that data and have those the kinds of socioeconomic, sociodemographic data collected to be more comprehensive, but the absolute mandatory reporting of that still has yet to pass. In Chicago, we have very comprehensive data, and this is a daily dashboard that is accessible to everybody to the public. And so we've been able to run a lot of data and statistics from it, just using like R, and it's updated every day. It really is a daily summary. And this is just a snapshot. You can do all kind of fancy things. And this is what I consider to be a gold standard that every major city with a reasonable infrastructure should be able to do, so that everyday citizens, that reporters, that scientists can tap into and really have a handle on what's happening in their hyper microclimate in their communities, and be able to compare them to other communities, so we can track what's happening within different neighborhoods and get a sense of what's happening in our city overall. Second is the idea of using risk and place-based strategies. We have typically thought about place-based strategies in terms of, well, let's do community engaged work because we know that it's a trust and safe and trusted place for us to be able to do this work with populations that may not be able to find their way into the healthcare space because of lots of reasons, which we all understand. But what we have done a little bit less work in, what we have not been as strong in, is thinking about how place in and of itself is a risk factor for disease. And so with COVID, we have thought about individual risk. And again, this sort of chronic comorbidity burden that in itself is a reflection of structural racism. But we also have thought more comprehensively, more intensively about the place-based risk that has been associated with the risk of acquiring COVID, the risk of transmission of COVID, all of these things that, again, deeply tied to racialized residential segregation that goes back to, the housing policies right after the Great Wars that made it impossible, nearly impossible, for Black and Brown people to get home loans and mortgages and get their life started in ways that were not the same for whites, where they were kickstarted with GI bills and other things to, on their way to the middle class. And that story was the reverse. It was, codified into law that African Americans were not allowed to have these same goods and services and opportunities for their service to the country. And that set up the process for continued investment and disinvestment in white and Black communities, respectively. And so those same communities are the ones that we now look at SBI markers for and say, correlations with COVID. It's not a coincidence. Nothing about disparities are a coincidence. It's always going to be traced back to some structural policy that we decided as a country to put in place, and then has now resulted in health disparities. And so we have been able to, with COVID, think more about that connection and that association as far as place. And so this is a paper that came out. Time is so elastic. It couldn't have been more than 2 years ago, right? Late last year, I think, with one of my mentees, who's just a supernova, looking at specifically census tract level neighborhood disadvantage with racial disparities and COVID-19 positivity within the city of Chicago. And I don't have to tell you the results. There's strong associations between that. There's also another paper that came out that has since been replicated in cities other than Chicago, but this was the first one of sort of a series that was produced in Health Affairs, and the first author was a medical student at the time at the University of Chicago. He's now an intern at Northwestern. And this idea of jail cycling, where you are not, well, we already know that prisons are hotspots of inequity and health injustice, but this is not the prison which account for so much of COVID, but we're talking about the jail system where people are arrested, frequently inappropriately, where they could have been given a citation. And that's what the cycling is about: inappropriate over-policing, where people are, taken to jail, having their masks and other forms of PPI removed, being in tight, cramped spaces where it's for sure you will get COVID if somebody in that cell with you has it, and then being re-released into society 24 to 48 hours later, now probably infected. So that process, particularly that was happening during a lot of the Black Lives Matter protests where people were getting unnecessarily arrested, accounted in Chicago for 55% of the case rate variance across different zip codes. And so that was a stronger signal than race itself, poverty, public transit use, and population density, stronger than population density. And so these kind of factors that have to do with structural inequities and place-based risk, where people are living and where they're, where they live, work, and play, the communities that they come from, the communities that are trying to work against structural racism, all of these have to do with ultimately health outcomes. And so this is the paper for reference, and then student Eric Reinhardt. This is something that was made an early map by one of our just wonderful sociologists at the university. This is a map of the city of Chicago. Areas in red are predominantly African-American, more than 90%. Areas in sort of the gold are more than 90% Latino. Areas in blue, more than 90% white. There's a little purple area. You can probably barely see it, kind of right in the middle of the city. That's Chinatown. And then areas in green, there are not that many, do not have more than a 90% dominant racial and ethnic group. And so Hyde Park is sort of right there in the middle of the red space. So it doesn't mean that it's not segregated. It could be 89%, but it's not 90%. So what you'll see popping up are little circles where Chicago test sites first appeared. So it starts out on March 26th of 2020. And there's so many slides I should show you, but I have a short amount of time. So I'm just going to tell you, as you can imagine, that the rates of case positivity and hospitalizations and everything else bad for COVID morbidity and mortality are in the Black and brown neighborhoods, in the yellow and red areas. The lighter burdens of COVID were in the blue areas. Yet, what we find is that the additional resources as far as testing, vaccination sites, and other things are predominantly and first in the blue areas. And so this, is showing you the rate at which they first started appearing and sort of the density of that. I guess it looks stuck, it's not. Okay. So just in those first couple of months, you see how, if you're at the extreme southern part of the city, how far you have to go, or like how few and spread apart the testing sites are for COVID compared to if you're in the blue parts of the city where you just almost can't, go a couple of blocks without bumping into a Chicago site where we were testing for COVID, despite the fact that the rates were relatively low. So again, this idea of thinking about place as as something more than just a setting for community-based interventions, but place itself as a risk factor. So using now SVI as part of our calculation for where we should be distributing vaccines, where we should be thinking about allocating scarce resources and how we should be doing that. So now that's becoming more standard as we're thinking about those things. So that is one of the lessons, I believe, from COVID that we have started to manifest as far as thinking about equity. A third one is the opportunity to repurpose ambulatory infrastructure for disease prevention, monitoring, and support. And so as a great example of this, Oak Street Health, which started out in sort of the Chicago area, is now branched out. They've got a site now in Texas, I believe, used the initial shutdown of outpatient practices, they're exclusively an outpatient practice, to think about opportunities to support their all of their patients. So they really had enhancements in their telehealth, and I'll show just one caveat to that slide, to that in the next slide, but they totally flipped what they're doing with their staff. They still had staff with really not much to do. And so they beefed up their behavioral health needs. They turned their entire front desk staff, who were clearly not checking people in, their social work, their vehicles that had normally been used to transport patients to and from the clinic, began being used to deliver services and supplies that their patients needed, food, medication, and supplies that helped people monitor and screen for COVID. So if they then got COVID, they would already have an O2 monitor at home. If they had hypertension and diabetes, they're getting extra supplies if they did not have them, and they're doing so in partnership with other parts of the city. One thing I always have to mention around telehealth is that most of the cases or the opportunities for telehealth are not equally spread within communities. And so this is a paper that came out in JAMA Health Forum that was just talking about the inequities in technology and how they have contributed to disparities in COVID vaccine distribution and as a significant issue, but that also has played itself out in primary care visits. And there's a team at UCSF that showed that, and others. And so not everyone is wired up. And so when we're thinking about innovations in technology, we have to think about those who are not fully, engaged in technology. And so I'm going to say this later, but I say it all the time. You have to plan for equity. You have to plan for equity, to plan for equity. And so as we're doing these kinds of things, you have to sort of make sure that we're not leaving folks behind. The next is for us to think more broadly about integrating medical and social care needs, not just for individual healthcare systems, but at the broader city level. And so as an example, one of the things that a lot of cities were doing were thinking about how they could safely isolate and support people who had COVID from their high-risk living conditions. They couldn't go back home and then infect everyone in their family. So trying to think about more and better housing support for people who are unsheltered, and then expanding those to maybe those who had shelter, but were just high-risk persons. And so one of the things that we did in Chicago was develop a racial equity rapid response team. Like 2 weeks after we were shown on the news as a poster child for one of the two cities that had the worst rates of disparities, our mayor got on. She's like, we are not going to be ashamed like this. So she immediately formed a task force and said, we're going to have a rapid response team to get on top of this COVID racial inequity that we have. And one of the things that we did was the entire city was leaning in. And so the Greater Chicago Food Depository then began doing things like working with the community colleges. And because there's such an immediate uptick in food insecurity and hunger in the city, that we couldn't, and I say we because I'm on the board of the food depository, couldn't meet all the needs that were coming in. And then there's a lot of people in the city who were not doing their regular job because they were shut down. So we leaned into city workers. And so a lot of the streets and sanitation workers who, were not, doing a lot of stuff they would normally be doing, cleaning offices and things like that. A lot of the community colleges that were shut down became food distribution sites. And so they would get food from the food depository, package them up using free labor that the city had, allowed us to utilize. And they were so happy to not have to be dealing with unhappy customers, who are coming in to pay their ticket violations or whatever, but to be doing a service and to be leaning into this community effort. Streets and sanitation will be delivering this to people. And so it has been a city effort of thinking about how we can all lean in together and provide this supportive social safety network. And it's those kinds of things, not only within healthcare systems, but the whole city's infrastructure coming together, and how we can maintain those ties, that goodwill, that sort of thinking about the common good after the immediate needs of the pandemic, that is going to ultimately lead to better health for the most marginalized populations. It can't only rest on the healthcare system. Next is the implementation of local protocols to share resources and patients. And so one of the big gaping holes in crisis standards of care, when they're activated, they have really good details on how you can transfer patients across state lines. If your hospital systems are shut down, if your state has declared a state of emergency and you have activated this crisis standards of care, what they have not done is say, well, if we're almost in a crisis, but we're not really, and only this hospital is affected, but we're not really sure what's happening across town. There are no standards of what to do in that situation. And what happened all over the country, including Chicago, was a complete mess, essentially. And so we had a Chicago reporter report on it. And so we had our tertiary hospitals that had additional capacity, but we're trying to keep that capacity on reserve in case, something else came up that they need to, have reserve spots for. And then you had all these smaller community hospitals that did not have the staffing, the ICU skills, and anything else, that were completely overwhelmed, and not being able to get their patients into a place that was safe. And so there's a study that came out in JAMA that said that these smaller hospitals had people dying at more than 3 times, that people had more than 3 times the odds of death in those hospitals compared to the larger hospitals that had a higher number of beds. And what we really need is to implement pandemic protocols. We have these protocols in place for trauma, for stroke, and we need a pandemic protocol that we really tried to push for locally here in Chicago, within the state. We got nowhere, and we need federal action to be able to have this happen within the state levels. Right now, in our current waves, we've had several governors who've taken over and said, we're going to just handle this ourselves. We needed that to happen the first time. And so, but we have not had action at the federal level to say, this is how we should be doing things. This is a protocol for what happens when things internally within the state just go to hell. And so this is the paper that came out in 2020 showing factors that increase morbidity within a hospital setting, and size of the hospital and the ICU beds is one of those. I have things in bold here. Using an ethical framework to plan for equity, especially around scarce resource allocation, because that's when the rubber really hits the road, when there are only a few of these things. We already see disparities in care allocation when there's plenty to go around. When there is not plenty to go around, the stakes are much higher. And we have seen all kinds of shenanigans with this pandemic of people pretending they were you've seen it all, pretending they were elderly, pretending they were minorities, pretending they were, essential workers, visiting poor neighborhoods, pretending they lived there. It's just all manner of mayhem. Then the governor of Florida trying to prioritize the wealthy donors to Trump for vaccines instead of the poor people who had increased medical risk. So it goes from just a regular bad situation to just an insanely horrible situation when there's just, less than enough to go around. And so you have to use an ethical framework that everyone, knows and agrees upon to plan for equity. And so I'm going to just dive into this for a little bit, because this is where everything fell apart. So balancing ethical principles. So things that we ordinarily may not, if you're not a bioethicist, think applies directly to people of color or to, disparities, maximizing benefits and life years and like all that stuff. Like what does that mean? But it does apply to us. It does apply to health equity. And so, maximizing benefits means that you're talking about the healthiest people. Who are the least healthy? Racial and ethnic minorities. Maximizing life years means that you're prioritizing the younger people and not necessarily the older people. And that's one thing to consider, because we know that racial and ethnic minorities don't get to be the old people as much. And then you can specifically think about talking about equity for the socially marginalized. And so just as an example, when we were thinking about when the ACIP was initially thinking about vaccinations for persons who were over 75, we're like, okay, well, that would be great, except that the average Black person doesn't live to 75. So that means that on average, no Black people will get the vaccine. So perhaps we should think about a different strategy. And that's what happened in Illinois. We lowered our age eligibility from 75 to 65. And a lot of other states followed for that very reason. And so thinking about, maximum life years is actually a health equity issue when you're, and so we have to be thinking broadly about the language of equity when we're in any circumstance, but particularly in times of pandemics and resource shortages. This is a paper that I co-authored with Zeke Emanuel and one of my favorite authors now, he's a lawyer, Govind Prasad, about specifically folding in equity when we're thinking about access to vaccines. Again, using direct language, not sort of the indirect language of other stuff. And so what we did was say, in addition to thinking about benefiting people, limiting harm, equal concerns, let's just say prioritizing the disadvantaged. Let's just use words that people we know talk in. Disadvantage and oppression, things like that, medical vulnerability. Let's call it what we know it to be. And this kind of language is ultimately translated into NAM recommendations about the mitigation of health inequities, and prioritizing the disadvantaged. And what we also found was that in this effort to allocate scarce resources to reduce racial inequities, some other things came up. So we have highlighted now that some of the algorithms may actually exacerbate racial inequities, like the SOFA scores. And I'm going to dig a little bit more into those. But when they first came out during this pandemic, we have realized that using certain algorithms in the ICU may undermine ultimately the trust in providers. And that is the last thing we need during a pandemic. And that paradigm is also relevant to as we think about rolling out new treatments, therapeutics, and vaccinations. So this is a paper that was done with one of our pulmonary, was led by or senior authored by one of our pulmonary critical care attendings, just recently finished his fellowship, where we did a lot of simulation of what would happen using different recommended protocols under crisis standards of care for patients in the ICU, should they need them under these different protocols. And it was with patients who had actually been hospitalized with COVID. And what we found is that using sort of a random lottery versus other kind of models like youngest first or a SOFA only score, and SOFA being for just to level set, a measure that you can use that predicts mortality in the ICU. So we use that to say, okay, this person has a greater risk of death. Perhaps we would rank them lower for getting a ventilator or getting other ICU resources if we really had to choose. And then some protocols use a mixture of SOFA and other kinds of things. But we found that if you were using a SOFA only score, which some states were doing, then that was the one that had the greatest disparities in allocation of resources by race. Will Parker was a senior author on this paper, and the first author was an ICU fellow who's now an attending in Florida. But we dug a little more deeply to actually look at that SOFA measure. And what we found is that it was overestimating mortality for Black people. So the main algorithm that we were using to figure out who was going to get resources in the ICU was overestimating the death rate for Black people. And so that meant that, because what we did was we looked at the real death rate for Black people compared to the predicted rate for Black people based on the SOFA score. And those rates were different. And so using the SOFA score was, and so these are sort of the graphs. And what ultimately meant is that we used three different sort of three different protocols. And under the most severe shortage, the most extreme shortage of ICU beds, this plan would have deprioritized 16% of Black patients from getting critical resources in the ICU based on the fact that the SOFA score was devaluing their score more than it should have been. And so we've been thinking a lot about this during the pandemic. Racism is everywhere. It's in the DNA of how we think about things and how we calculate things and clinical algorithms. And all of this has come under scrutiny during this pandemic. And so Bernie Lowe and Doug White came out with a paper thinking about how to specifically mitigate inequities within the ICU and to promote justice. And some of them had to do with thinking about the triage guidelines. One is using a correction factor to reduce the impact of structural inequities. And what that means is for people who are living in the highest, in zip codes with the highest rate of neighborhood disadvantage, again, getting back to that idea of place-based risk, they would get additional points to help adjust for that when they're being triaged. Other considerations that they were talking about in this sort of third bucket was what I had mentioned earlier about the need for hyper-local state systems to be able to transfer patients and giving additional resources to those hospitals that typically have been under-resourced, those smaller community hospitals that don't have the staff and the resources, which are typically disproportionately in Black neighborhoods. And those are the very neighborhoods that are getting the sickest patients. And so again, planning for equity, seeing it where it is, having the data to know where it is, and then planning to try and balance that out. These are two papers that William Parker, Govind Prasad, and myself did in Health Equity and in JAMA Health Forum, and ultimately we sort of combined them with this sort of practical recommendation because we saw the complete shenanigans that were happening across the country. And we're trying to say, okay, we have these bioethical principles, but you have to actually think about how we're going to roll them out because many people were not reading our papers. And so, what? They're not reading our papers. And so, we have to, also think about these are the practical things that we have to do. You can't just turn on a system and say, okay, everybody go sign up. Most people don't have computers who really need this, and so here's what you can do instead. And so a number of recommendations about how to do your system, how to think about engaging the public, how to think about registration. We just laid out in a how-to recipe for public health practitioners. And then there are others who have, well, this is one of my papers, but who've been talking specifically about what cities have done from a public health practice perspective that has had bioethical principles to help others think about how to do this. Again, ethical frameworks where you're planning for equity. And this was an experimentation that was done in California where they used health equity into they factored that into how they were going to be using their reopening plans. So a certain community couldn't reopen their businesses if the most challenged communities, as far as neighborhood deprivation, had rates of COVID case positivity that were really out of proportion to the communities that were least deprived. Because then what you're doing is asking for the poor and marginalized who are at highest risk to come into the affluent areas and be serving drinks and doing all this other stuff, and then going back to their community after being highly exposed. And so that's not fair, and so trying to, again, plan for equity. And so we're all in this together, thinking about the good of the entire community. And so these are just things that we should learn from this pandemic about how to operationalize this. And then last, I would say address and rebuild trust in all institutions. And so we know that there has been a lot of vaccine hesitancy and sociopolitical distrust, particularly amongst racial and ethnic minorities. And there's a difference between distrust and mistrust. And so this distrust for racial and ethnic minorities has really been rooted in a lot of the structural inequities in government institutions and policies that may not be exclusive to healthcare, may be rooted in police and criminal justice or public education, child welfare and housing. And it's not a compartmentalized construct. If you don't trust, the thing I always remember is that someone told me, our president, talking about Trump, is trying to kill us on TV every day. You see that, right? So why would I think he's not trying to kill me with this vaccine that you're promoting, Dr. Pete? And so I'm like, well, that's a good point. But let me have a prolonged conversation with you about, let's walk through all of those steps together. But these are real issues for real people and how they're making decisions about, risk and benefit for their families and their communities, given generations of how they have made gambles and how they may have lost those gambles, and trusting that the institutions that are there to protect and serve may or may not have come through on those promises. This is a paper that I wrote with Bernie Lowe and with Doug Opel, talking about addressing this mistrust, which I would actually say is distrust, about the COVID vaccines amongst patients of color, specifically addressing the socio-political distrust that is institutional and how that has been applied to COVID vaccines. And with that, I will end just remembering those sort of 7 lessons learned. And I'm happy to continue the conversation on Twitter, where I spend half my time living. And I'm open to questions.
Leave that slide up for just a few seconds there, because yes. I think these are really take-home messages. So I want to make sure I capture them. There we go. Thank you. Awesome. So let's see. So are you ready to take questions from us?
I am ready.
That was amazing. I mean, I don't even know what to say, but I mean, I've been following your work for years, and then over the last couple of years, really like leaning on some of your key papers, especially that last one you just mentioned, directly with the residents in clinic, with how to talk to patients about some of these issues that were coming up on a day-to-day basis. So I just want to thank you. And I've been seeing a lot of great comments in the chat about the fantastic nature of the work and how it's being translating research directly into practice. Just exactly what we need during these times. Thank you. I'm going to stop talking so other people can ask their questions. So we can open it up. You can either put your question in the chat. Okay, so there's one person who's saying, do you mind elaborating more about distrust versus mistrust?
Sure. So I myself didn't, technically, semantically, you can use them interchangeably. And I have for most of my life, which is horrible because I consider myself someone who thinks about trust a lot, but really there is a nuanced difference. And so mistrust really is the idea that you aren't trusting something based on a perception that it's not going to be good for you, but that hasn't really been proven true. You just have a hunch that something's going to go wrong. Distrust is more like, it has already happened. It has already been wrong. And I know that I don't want more wrongness to happen. So it is a well-earned sense of a lack of trust. So my, family, my community has had a generational history of bad experiences with X, Y, and Z. And in fact, so-and-so happened. I think there are many of us who can say that. And so that kind of, and especially for the African-American community, where our whole survival strategy has been adapted to this idea of distrust, and may have good short-term gain, like you stay alive, but the long-term gain of being healthy the idea of like not letting people in your door, not trusting that, what so that the institutions are necessarily telling you the truth, that these vaccines aren't necessarily going to be good for you. Like all of that, you know, is not it's not in our best interest in the long term, but we have experienced over and over, like Charlie Brown and Lucy, that we have not gotten the right end of the stick. And I was having a conversation earlier, and I was like, really, to be honest, Black people are probably too trusting, like given all that we've been through, we should probably, have more distrust, because if you think about how quickly rural white Americans developed a mistrust of this vaccine based on hearsay from the musings of a mentally unstable president, to numbers that were equal to African Americans who for hundreds of years have had daily experiences of, nothing but horror with, our institutions, that I think that we might be too trusting, and so, we are loving and forgiving people, but y'all need to stop trying to kill us, chasing us down in the street, stop killing us, is that too much to ask? And so I think that, that's sort of the essential difference. And that means that we have differential strategies and to address those things. And so if the underlying issue with distrust is that there's someone who continues to break and not honor that trust, then the solution is those institutions have got to square up and do right, have got to say, hey, you know what, Lucy, I'm Lucy, and I have been doing wrong all this time. And Charlie Brown, I swear this time I'm not going to do it, and I mean it, and I'm sorry. And here's a football. I'm just going to put the football down, Charlie Brown. We're not going to play football anymore. In fact, we're going to do a whole different game and be serious about it, But where we are in this country, Lucy doesn't want to even admit that she's playing football. That's where we are. And so it is all this gaslighting and persistence and these bad habits. It makes it really a challenge for marginalized communities to accept that this time it's going to be real. It's going to be right. And so it's harder to rebuild trust when it's continually being eroded in another space. And that's what a lot of us are working against.
Wow. Powerful, powerful words. So speak truth, my dear. I'm going to turn over to Chidima Ibe for her question.
Thank you so much. First of all, this was such an incredible talk, Dr. Peak. And to echo what Dr. Cooper just said, I think I love that you are willing to call a thing instead of using all of the, this flowery language that we tend to, favor in academic spaces. So first of all, I just wanted to thank you for that. I was just curious about, so along the lines of what you were just saying about trust and how trust in one sphere can influence the extent to which you're willing to trust in other elements of things that our people are willing to trust in. And I was thinking a lot about Chicago and its leadership and the ways that its leadership is perceived, because Baltimore City has similar problems. And I was wondering how you and your colleagues have gone about building relationships within, I guess, the governance structure of the city in a way that kind of cultivates trust, but still acknowledges, some of the, I'm trying to figure out how to word this, but is cognizant of some of the shortcomings ethically that have emerged. I was curious about how you've been able to do that, not just in the context of COVID, but through your other work too, which I have also been following for a long time. So thank you.
Thank you, sweetheart. Yeah, so first I'll just say for better or worse, am always a transparent truth teller, at least the truth as I know it. And someday it's going to come get me. But I just can't. I just can't, you know. So yeah. What I have found, and that's part of the reason probably that I speak the way that I do, is that I think that clarity and transparency, honesty of intent and word go a long way in building trust. And that, you know, I try to be, and that's just how I try to move in the world. In my day job, you know, we you know, the head of the Department of Health and the mayor, we are a constant, and at our institution, we're constant irritants. I know that we are, because, you know, you publish these papers, we have more in the works, you know, in press, that are just saying like these are things that are happening in Chicago that could be better. And you know, they are the result of long entrenched structural issues. It's not that the mayor decided that this was a priority, but this is what's happening in our city. And you cannot fix a problem that you do not fully understand. And so we just believe that we have to be honest about what's happening, regardless of who is currently in positions of power. And we still want, you know, I was on the rapid task force. I hadn't got kicked off yet, you know, and I think we've been respected for the work that we do, you know, and because we have found a way to work, we see a lot of the journalists that we work with as, you know, collaborators who are fighting for justice in their space, just like we're fighting for justice in our space. I think that gives us additional social capital, because things that are happening that we see, people might be afraid to fire me, I don't know, or say something too horrible because they know they have a lot of social reach. I'm not sure, but I just feel like I'm able to do the work that I want to do unhindered. I'm always close to crying, but what I will say is that I always figure that I have skills as a physician. I can always get another job. The people that I answer to, you know, are my ancestors and my, you know, and my Lord. And there's so many people who have come before me to make our work and my life possible, that, you know, the little thing that I can do to write a paper or to sign off on a petition or whatever is nothing given the sacrifices that others have made in this struggle. And so, you know, it's a non-starter for me personally to have a lot of hand-wringing struggle about, am I going to do the right thing? And so I don't always get it right, but I try to.
Thank you so much. Thank you.
And now you guys know why I love her, right? Wow. Well, we have so many more. We have more comments and questions in here. Ulysses was asking, how did you handle the white body historical racial bias in the ways in which they may operate normally? One person said that. And of course, everyone's thanking you for your amazing talks. So I don't know if you want to take that one. There's another one after that.
So the question, how did I handle what?
It says white body historical racial bias. I think in some ways you may have already just told us some of that. But if you want to add more to what you said, that would be fine.
Yeah. You know, I was born and raised in Tennessee. And so I grew up, I have been fighting racism my entire life. I was telling my kids yesterday that I had gotten, for some reason, I can't remember. They asked me if I had ever gotten a death threat. I don't know how that conversation came up. That should be the bigger thing I remember. But I was like, I don't think so, but maybe when I was in college. And they're like, what happened? And I was like, well, I was the president of the Black Student Alliance, and we were doing a lot of protesting, and we were trying to get this board of trust member fired because he was doing these racially inappropriate things. And I got some hate mail from the Klan. And I was like, I think I might have it saved. I may have put it in a scrapbook. And they were like, why would you save that in a scrapbook? But I feel like I've been doing, I've been fighting in this way my whole life. And so who knew those skills would be relevant to my professional job? So I just put my head down and try and do the work. But I know, I guess there are two things I always say, like, don't mistake my kindness for weakness, and don't start nothing, there won't be nothing, So I love people, and I love to give hugs, that's my go-to. But like, I'm always ready to fight.
Well, I love like the fact that you are so down to earth, and that you actually use humor in a way that really catches people off guard. So they actually have to laugh at themselves and look at themselves again. So that's one of your talents, I have to say.
Yeah, it's true, So yeah, like, I think, somewhere in that strange mixture of they like me, but they fear me. I don't know what it is, but I have managed to carve out some space where I don't really, people don't bother me, I don't know why. I think maybe I've had a few choice interactions that have let other people know that they probably shouldn't be bothering me. And then I can just be my usual self. I can, be happy and pleasant, and because they know that that's a choice. I don't know, but I don't, the other thing I do is try to stay in community with like-minded people. Not everyone who fights for justice looks like me. Most of the pictures of the people that you saw on those slides were not African Americans, but they are my warrior friends. And so I try to be in a space of people that I hold dear, that are my ride or dies, colleagues that I trust. I've loved Lisa for decades, people that I know have my best interests at heart. And so it's easy to be brave when you know that you're in a space surrounded by people who will protect you, and who care about you, and who are fighting the same fight.
Thank you, Monica. Pedro, Cruz.
Hello. So just want to thank you, really just offer deep gratitude for really all the work that you've done, and also just your sharing with us today. You've inspired all of us. And I'm was really happy to hear that not only do you do yoga, but you're an instructor of yoga, because as I'm hearing about your fight, that we're so grateful for, it did make me worry about what it puts on you. But I'm glad that you have a means to to sort of bring that down, and so just thank you. I wanted to ask you, given that your work and certainly the work of other people has really led to a lot of attention being brought to these structural inequities in the setting of the pandemic. And we've been able through your writings and everything to shed light on it. And there are people that are newly paying attention to these issues. And I was wondering if you could maybe share with us what you think should be the next thing that we try to sort of capitalize on now that we have at least some greater attention than what these issues were being paid 2 years ago, right?
Mm-hmm.
So just wanted to get your big picture thoughts on that.
Yeah, I think two things. One is that we have to be careful and wary of the fact that every time there's progress, there's backlash. And we're already seeing that. I don't know if anyone else is a huge fan of This American Life. But I have listened to every one of those shows like 3 times, and they just had one called Talking While Black that came out a couple of weeks ago, and it's extraordinary. And it was just mentioning, it had a couple of different case studies or little stories, Act 1, Act 2, where it was just talking about how at first everyone was like, Black Lives Matter. Yes, you too. And then now where people are like, I don't want my children to read about, Rosa Parks. Those books are being banned from libraries for like second graders. And, critical race theory, nobody's teaching critical race theory to 4-year-olds, just triggering language that we all know just really means nobody is trying to be honest about history and Black history in the school system, because to purposely keep people, particularly white people, unaware of what has happened is part of the overall strategy of maintaining the status quo, so that white ignorance is the greatest tool for white silence. And so we are in that phase now where people are kind of like, oh, I'm kind of tired. Whew. Wearing that t-shirt was difficult, and so yes, some people are still with us, not as many as were, in the beginning. And we're starting to see some pushback, just like we got Trump because there's too much Obama loving. So we have to be wary of that and push harder. But 2, I always say, the other thing I always say is don't talk about it, be about it, or don't just talk about it, be about it. And so we have to think about now trying to cement all of those promises that people were making into practice right now. So I actually took a role as a senior associate editor at Health Services Research. And it's a fabulous journal, and I love it. And I am totally in love with the editor because he's so amazing. But when he first asked, I was like, Health Services Research, that's kind of dry. But I published there, but that's not my usual go-to journal. But he's like, I am committed to, fighting racism in this journal. Will you join me? And I'm like, oh, yes, I will. And so that's what we've been doing, and so we need that in everybody's journal, So any of you, when you get these letters, because they're coming, from JAMA and from everyone else saying, oh, we think you'd be excellent to be a so-and-so, say yes, because the fight is real. And so we have to now hold all of these organizations and journals and institutions accountable to the pledges they made several years ago. And there are all of these micro issues within each organization. And Lisa, I can only imagine what you have seen. I'm sure it has probably grayed your hair. You look fabulous. I don't know if your hair color, I don't know, but it should have grayed all the hair on your head. So, it is crazy. And so I think our next step, in addition to, continuing to publish the scholarship and try and push the fields and take advantages of the grant opportunities that are out there, and, mentoring others and pulling people, along with us, all the stuff that we've all been doing all the time, is, keeping all the institutions accountable for what they promised, over the past several years. And so when they say they're looking for help, even though we all have 7 million other things to do, say yes.
Fair. Thank you.
Well, everybody's, I think, so inspired by your talk and also by your authenticity. Everyone's talking about that. And I could have told them that a long time ago. So I don't even know why it took so long for us to get you here. But anyway, you're here.
Thank you for having me.
Yeah. So are there more comments or questions? I think we have so much that we can draw upon from today. I mean, to help us as we, embark into this new year, this new chapter. I think this was very helpful in, giving us some opportunity to reflect, and in a really, I think, giving us a framework too for reflecting. I think we've talked about lots of different topics, but I think you really gave us a different way of thinking about this, and your clinical experience as well as your ethical training, I think, really shed some light on some of the key issues during the pandemic that we haven't actually had the time, I think, or the opportunity to delve into at this level. So really, really appreciate that. And we're looking to see what other amazing things you will continue to do. And we're also here, of course, as you said, always here to be with you in the struggle and to have your back at all times. So I just want to reiterate that and sincerely thank you from the bottom of my heart on behalf of the center and all of our community partners, as well as our academic collaborators and our trainees and faculty members. If no one else has any other questions, I think we will be on our way, sadly, because we're having such a good time. But we will carry the Al Green theme, and maybe some of us will go back and listen to some Lauryn Hill as well.
Yes.
And reflect upon what we've learned today from you. So thank you.
Thank you all so much. These sessions are really inspiring for me too. Just speaking to, being in a safe space and talking to like-minded people really helps me as well. So thank you.
You're welcome. I will be talking to you soon.
Yes, I owe you stuff.
Thanks, everyone. And we look forward to seeing you all next month at our Black History Month Health Equity Jam session. So stay tuned.
Good night.
Okay, bye.
Thank you.
Thank you so much, Dr. Peak.
Oh, bless you, sweetie. Thank you.